Good afternoon, everybody. Thank you very much for joining us today in Healthmonics' next webinar edition. This one today is going to be on cracking the code of the MIPS cost category. We are joined here today by our CEO, Lauren Patrick, as well as our MIPS cost analytics product owner and expert, Daniel Patrick. Hello, guys and ladies.
Hi, Mike. Good afternoon.
Good afternoon. Good afternoon. All right. So just a couple things as background to let everybody know. There is a handout down the bottom of the page of this presentation, as well as I will send it to you after the presentation is complete, so you'll have it either way. I'll also be sending a recording of this webinar so that you can watch it at a later time as well and take notes and so forth. Also, there is a question box here where you can ask questions to Lauren and Daniel and myself. However, I do believe that this is a very full webinar. We will try to get you all of your answers after the webinar if we can. So what are we going to be covering today? Today we'll be covering the MIPS cost category. What do you need to know about the MIPS cost category? Cost data, why is it important and the major impact on your score? And cost and MVPs, how the cost category relates to MVPs and the future of where CMS is going with their MIPS and these quality programs. So the MIPS cost category, I'm going to toss this up. This one's still me. If you're MIPS eligible in 2023, the merit-based incentive payment system under MIPS evaluates your performance across multiple categories. We've all been very familiar with quality improvement activities and promoting interoperability for many years, and cost has always been lingering in the background as it has been taken out by CMS in 2021 and 2020 due to COVID, and prior to that, it really didn't impact your score enough to make a difference. But right now, with cost data included in 2022 scores, we have seen a great impact in scoring across our entire provider population that we have here at Healthmonics related to cost scores being introduced. The MIPS final score ranges from 0 to 100, combining the weight for each performance, and with cost being 30% of your score, it is impacting your score a great deal. In 2022, which was really interesting and a great, fantastic surprise for us here as well as our customers, is that those that scored a perfect score in 2022 are going to receive an 8.25% increase in their Medicare Part B in 2024. That's the largest by a very wide margin for scoring. So finally starting to pay off with some of these scores. And then in 2023, the performance affects payments Medicare in 2025. So any work that you're doing this year is going to affect your work in what you see in 2025. So reporting in 2023, eligibility is still the same at $90,000 in Medicare Part B charges, 200 Medicare Part B patients, and 200 plus covered professional services. The exceptional performance bonus was eliminated this year, so last year was the last year for it. However, a lot more providers that aren't paying attention to things like costs are going to be penalized in 2023, and therefore we do believe that while it may not be 8%, we should see some pretty high returns and scores for 2024. Okay, I am going to toss it over to our team as they're going to go through the slides, and I'll be back with you guys at the end. Please ask your questions.
Thanks, Mike. So this is Lauren, and when we talk about scoring for just the cost category, so the cost category is new to most people. I think, as Mike said, we didn't have it for a couple years, and it just came back last year. So it's time to relearn how it is calculated, and then talk about how we can view it and what can be done about it as we move forward. It's weighted, as Mike noted, at 30% for individuals, groups, and virtual groups, and also subgroups. That's not on here. And then it's weighted at 0 for APM entities reporting via traditional MIPS. For a cost measure to be scored, the individual or the group has to meet or exceed the case minimums for the cost measure. The case minimums for the measures vary. For some measures it's 10, for some it's 20, and for one it's 35. So we'll get into that a little bit, but you have to have the episodes, as we call them, and then you need to meet a minimum in order for that measure to apply. If you have just one measure that's attributed to you or your group, the score for that measure is your score for that category. If you have more than one measure that is calculated for your group or individual, then what happens is CMS takes an average of those. And if at the end of the day you don't have enough episodes for any of the measures, then you don't get a cost score, and CMS will reweight the 30 points into other categories, depending on whether you're a small practice, large practice, and which sort of MIPS you're reporting. So the MIPS cost category, CMS, under the mandate from MACRA, is mandated to measure both cost and quality. They want to try to help providers pay attention to the cost of care for Medicare patients. What they've done over the years is they identify areas where the highest spend is occurring for Medicare patients. So diabetes care is one. In certain inpatient conditions are others. Hospital stays in general is another one. Total cost of care is another one. So they're really looking across the spectrum of where the claims are coming in and then deciding which measures they want to evaluate to give providers feedback and then to include in the scores. The measures are intended to make providers aware. I think you become pretty aware when you get a score at the end of the year. And although you're aware, then the question becomes, what does it really mean? And we'll dig into that a bit. Measures are adjusted based on patient risk. We all know that, certain patient populations are sicker than other patient populations. Certain patients inherently are going to cost more to take care of. So CMS is trying to put some of those adjustments in. We can argue the merits of what they're doing, but that is part of the process that's being implemented. The purpose of the cost category is to reward eligible clinicians for cost-effective care. Again, we could spend a whole hour talking about that statement. These measures, you as a clinician do no reporting. CMS takes all of the claims that they receive for patients across all providers, and that's how they calculate these cost scores. So there is really no way you as an individual can understand what your cost score is going to be for a variety of factors, and we'll go through that a little bit more. And at the end of the year, what CMS does is they benchmark the entire clinician population against each other to determine scores. So the average score basically is going to be kind of midland. It's going to be around 15 points out of 30, which as we look at scores going forward, if for 2024, as they've proposed, you're going to need to hit an 82, and 15 points are already probably going to come off your cost score unless you do really well, you're really close to that threshold. So that's one reason we really need to start trying to pay more attention to this. So there's 25 measures available in 2023. I think these are the same measures that were available in 2022. There are 5 more that are proposed for next year, and we can talk a bit about those, but the 25 that exist right now, the biggest one by far, the one that impacts the most providers is TPCC, which is the total cost of care for a patient across all costs. The second most applied measure is the MSPBC. We call it MSPBC because it is a little bit different than the Medicare spending per beneficiary that we see in the hospital programs. Similar but different. CMS is trying to align measures as much as possible. So be aware of that. If you've already been involved with hospital-based spending, perhaps this will look somewhat familiar to you. Then there's 15 procedural-based measures, and these are typically, as the name indicates, a pretty specific procedure that clinicians perform. There's 6 acute inpatient medical conditions that are being measured, and there's 2 chronic condition measures. Next year, they're proposing 3 more chronic conditions, depression, heart failure, and low back. And then there are a couple more procedure and acute measures that they're talking about implementing. This is a list of the 25 that are currently in play. You can see they really run the gamut. CMS is trying to create and apply measures that apply to all clinicians. And so there is a wide variety here of the measures that are being deployed. You can see here some of them are procedural, some of them are the inpatient, there's a couple of chronic conditions, and then again, TPCC and MSPB. If you want to see those measures, full specifications, there's 2 documents you can use. You can go to the CMS website and you'll find a measure information form, which will tell you in text about the measure. And then in addition, there is a codes Excel spreadsheet that will tell you all about all of the codes that are used throughout the measure calculation process. So those are available on the CMS website. We also link to them off of the HealthMonix website. So again, oh, can you go back a slide, please? So here is a list of different types of specialties that are already being applied the cost measures for the most part. And you can see they really run the gamut. So CMS's goal, like I said, is to cover all specialties. Next slide. So here are some examples of measures that are being attributed. The low back pain and depression are coming next year. The rest of them are already in play, and this is just a short list. If you're interested in finding out about which measures apply to your specialty, you can reach out to Mike's team and they can help you perhaps identify based on either your 2022 feedback reports or talking about what specialties are involved in your clinical group. So as I mentioned before, TPCC is the most attributed measure. This is a measure that was one of the first measures that were included in the cost category. When it came out in the cost category, there was a lot of pushback from clinicians saying that they really didn't feel that that measure should apply to them. TPCC is intended to measure the total cost of care, and it's intended to have a clinician take responsibility for holistically looking at that patient and making sure that that patient is getting appropriate, cost-effective care. So it's natural that providers like primary care, internists, those sorts of clinicians would have this measure applied to them. What was happening because of the way the measure was calculated was a lot of specialists were getting this measure applied to them as well. So a dermatologist or an ophthalmologist was getting the TPCC measure applied to them, and they pushed back and said, I'm really not equipped to provide an overall look at this patient's total care. So CMS in 2019 revised this measure significantly, and they said specifically, these are the specialties that we're going to apply this category to. So this measure to. So if you're one of these specialties, you can get this measure applied to you. There's some exceptions based on a few billing codes, and again, we can talk through that with you if you're interested. But they've really tried to limit the subset of clinicians that this is applied to. It's still covering about 30 to 35% of all clinicians. One of the issues that still exists with this measure, however, is that if you're again, I'm going to use the derm practice as an example. If you're a derm practice and your doctors are coded as dermatologists, your PAs and NPs may not. So CMS will still attribute those patients to those clinicians. And so that's one of the feedbacks that folks are giving to CMS. CMS is committed to, if not required to, look at these measures every few years and revise them. So as you see these measures applied to you, as you have feedback, please submit that to CMS, because they do, like I said, put together a technical expert panel every 3 years or so to relook at the measures and then make changes going forward. That was a long soapbox, sorry guys. Okay, so now we're going to get into a little bit, so that's kind of what the measures are. I'm going to talk a little bit about how the measures are calculated. Each measure is calculated via the 6-step process. And so we go through and we trigger the episodes, we look for relevant things that are happening in the claims. Then we do attribution, we figure out who that patient or that episode should be applied to. We include or exclude services. Risk adjustment, as I said, is done to try to accommodate differences in patients and episodes and complexity. And then we calculate the measure. And I'm going to go into each one of these steps just a little bit further. So a trigger. A trigger is where an episode starts. The episode window can actually include things that happen before that trigger. So if a patient, for example, is going in for a knee arthroscopy, CMS will look back a certain period to look at related services such as different tests or films that were done beforehand that relate to that. And they want to look at the overall expense from before the episode starts, if it's relevant, till after the procedure is actually done, and then include all those costs. Some windows do start at the trigger event. For example, most of your acute inpatient episodes, those just start when the patient is admitted at the hospital, and then they move forward. There's 3 different kinds of triggers that are most prevalent. For an acute inpatient episode, it's normally triggered by an inpatient stay with a relevant DRG, diagnostic related group. For example, sepsis is a measure, COPD exacerbation is a measure. There's about 6 of these that are currently active. Procedural measures are things like a knee arthroscopy, melanoma resection, colonoscopy, things that are very specific procedures with very specific CPTs. And chronic conditions are typically triggered by one E&M code and then a confirming claim, and then they can extend beyond that for a given period of time. So there's 3 different ways that the triggers really occur. Attribution then is required to determine, so now that you have a trigger, who are you going to attribute that episode to? So each measure, again, employs its own attribution method. An episode can be attributed to multiple providers. So for example, if you have a primary and an assisting clinician in a certain procedure, both of those can be attributed to that patient. If you have 2 clinicians taking care of a patient in the hospital, both of those clinicians can be attributed that episode. For the acute inpatient measures, the episode is attributed to any clinician groups that build at least 30% of the inpatient E&M claims. So you can see there that you could end up theoretically with up to 3 different groups having that patient attributed. For procedural types of measures, It can be attributed to any NPI who billed the trigger code. So again, the physician that performed the knee arthroplasty. And then chronic conditions can be attributed to clinician groups that billed the E&M code and the confirming code. And again, we've seen patients that are attributed to several different groups because the patient is being treated by several different clinicians. So there's 3 different ways mainly that patients and episodes are attributed. I know this is a lot of detail. So there's a lot here that I'm covering. If you have specific questions later on, happy to answer. When we look at the overall cost, so the cost isn't just what you as the clinician are doing, it's all the related costs. It's the anesthesiologist, and it's the aftercare, and it's the tests and diagnostics, and it's a lot of the different costs that are involved. But what CMS does is they do standardize the payments. So the payment for a certain procedure doesn't vary except for very specific reasons. I think some of them are specialty adjusted, some of them are regional adjusted, but the payments are standardized. So it really isn't dependent upon what the clinician is billing. It's based on the algorithms that are used to standardize the payments. Next slide. Again, if you go back to those Excel spreadsheets that I was referring to, for each of the measures, CMS has developed a long list of the services that are relevant to that episode. And again, a lot of debate about what should be included, what shouldn't be included. Most of the measures have very specific lists in terms of what's included. For TPCC, they include everything. For MSPB, which are your hospital episodes, they include everything, and then they have a list of exclusions that they apply. So there's different ways that they do service inclusion. Next. So we do exclude certain patients. So patients are excluded for a variety of different reasons. For example, if they weren't continuously enrolled in Medicare, I'm not going to read through all of these, but if we can't figure out the main clinician attributed to the episode because it's not in the billing data, then we will exclude that. There's various reasons that patients can be excluded or episodes can be excluded. Risk adjustment is super interesting to us geeky types. It accounts for factors that we feel, that CMS feels impact the total cost. CMS, when they develop these measures, they bring together a group of what they call technical experts, which are clinicians that specialize in the area. And then they typically bring in folks that are involved in measure development overall. And what they do is they attempt to identify all of the various factors that could influence the cost of an episode. For example, typically a patient's age. If a patient is older, typically it's higher risk. If a patient is on Medicare because they're disabled versus they're on Medicare because they're older, then that brings with it a certain risk. If a patient has certain chronic conditions, that brings a certain risk. If a patient has comorbidities, that can bring a certain risk. So we bring all those factors in and do algorithmic, we happen to use statistical software to evaluate all of that, which is similar to what CMS does. And then they come back with risk factors. Those risk factors are then applied to each episode for each patient to figure out kind of how we're going to risk adjust this individual episode. It's done on an episode by episode basis. Okay, so we've gone through and we've figured out all of the episodes based on a trigger. We've figured out who to attribute it to. We've added in services. We've excluded services. We've done risk adjustment. And now what we're ready to do is actually calculate a measure. So here we look at the total observed cost for the episode, and we judge it against what we think the cost for that episode should have been based on the risk factors, based on all of the data that we gather from from the entire patient and clinician population across the US for that year. And we develop a ratio of what we expected the cost to be for that particular episode and what it actually cost for that episode. We take all those ratios and we calculate from that what your average ratio is. We apply that to the benchmark, and that's your measure calculation. So a lot of numerical, I was going to say rigmarole, expertise goes into calculating these measures. And at the end, we end up with a total cost calculated for a measure for a clinician group. Okay, a little bit more about TPCC, because a lot of people are very interested in that. So this is just a little bit deeper dive. For each episode, we look for one E&M code. We look for one additional primary service. We do exclude specialties, as I said before. We also exclude clinicians that are of the specialties we include, but they have at least 10 or 15% of their billing for global surgery, anesthesia, therapeutic radiation, or chemotherapy. We construct a risk window, and the risk window is long for TPCC. It's a year. And not only is it a year, but if we find that there's what they call a reaffirming or reconfirming claim within that period, it can actually go on for 2 years. So you can end up getting a patient attributed for over 2 years. And then we go through all of these steps that that I talked about in the prior section. I'm not going to go through these again. So MSPB is the other measure that hits a lot of providers. Next slide. There's 2 different kinds of MSPB-C episodes. There's surgical, which are very procedure-based, and there's medical, which are the based on the DRGs when the patients are admitted. Again, I'm not going to go through the details here. I think I've covered a lot of this. Cost measure scoring, I think I'm going to turn this over to Daniel.
Thanks. So we're going to talk about benchmarks. These are the values that they use to determine where your score. So I guess first of all, a measure score in CMS terms is not your points for cost, it is a dollar amount. So the benchmark is the average of that dollar amount for the entire country, and that is used to determine where your costs fall on the spectrum, and then that's how your actual cost points are determined. So you can see for each measure, there's a separate benchmark from comparing all of the episodes across the nation. And if you're familiar with MIPS quality, I think they use historical benchmarks, which are from a couple years ago, and these cost benchmarks are not calculated until the full year's data has been calculated, basically has been observed. So you can see for MSPB-C for 2022 here, the average performance rate seen across all the providers is $24,685. So then that, I guess we can go to the next slide. So the benchmark is used to create these decile numbers. The benchmark is obviously the average, so that falls around the 5-point range. And then using each 10% of other values, they calculate which costs would fall in those ranges. And then we can see if you're within a certain range, then that's the decile that your score belongs in. So they're based on the provider performance ranges. They go from 1 to 10. You can see that the 10th decile is where you would ideally like to be. 10th decile means you're going to get 10 points for the measure. So you can see that, I guess we can go to the next slide. Yeah. So lower cost equals a higher score. So you can see that the decile 10 range there is the lowest, and decile 1 has the highest amount. And I think theoretically, your cost could be above there, but that's the highest cost that was observed in this range. So if you get anywhere below that 21,724 amount, you're going to get the highest score. So we have a couple examples here. If your average cost was $27,000, you can see that's in the 2 to 3 range. So you don't just get the 2, you get the decimal value within the range as well. So we kind of went over this before, but your score, if you have one measure, then that measure determines your entire score. If you have multiple cost measures that you're eligible for, then those will all be added together and used to determine a total score. And then if you have no measures that you're eligible for, you will not be scored on the cost category. So this is what on our site, what this score calculation looks like. Here's where you could see all of the measures, including ones that you're eligible and ones where you're not eligible. You can see them listed here, organized by the score. So for each measure, we have the number of cases or episodes. For most measures, it's called an episode, but for some of them, they're calculated differently, so they're not technically an episode. And then we have your cost, which again is called your cost measure score. And then we have the national benchmark, which is which your score is being compared to. And then the decile score would come from that table we looked at a minute ago. And you can see based on how high above or below you are, the benchmark, then you will get a higher or lower score accordingly. So once I guess actually, can we go back to that last slide? So you could see for this example, there are a lot of measures that have a yes in the included column. So this means that they are eligible and they are being scored on all of those measures. So you can also see on the right side that each one of those has a potential points value of 10. Any measure where you are found eligible, you can get up to a 10, obviously because of the deciles. So each score is first measured out of 10, and then we add up all of the 10s and we add up all of the scores. And then the ones there at the bottom have no's, so those would not be included, and we don't show any type of score for those. So I think when we look at the next page here, if we can go back to that. So the total was 150 for 15 measures, and the actual decile scores added up came out to 95.7. So you can see that's a 64% score. So what we do then is knowing, assuming that this is a practice who will qualify for regular cost without any kind of reweighting, they will get a score out of 30. So we know they'll get 64% out of that total 30, which would be a 19.2.
Daniel, can I go back to the prior slide for a moment?
Yep.
I don't mean to break your stride, but somebody asked, and I think this is important. When you're looking at these numbers, so if you look at melanoma resection, for example, in this particular case, you can see that for your 10, your cost on average, your measure was $1,165. That $1,165 is not necessarily all billed by your 10. In fact, it probably wasn't all billed by your 10. So what CMS is doing, so this is a screen that's replicating all of the algorithms that CMS puts together. So what CMS is doing is adding up all of the costs for that melanoma resection episode, which is from before the trigger till after the trigger, probably 30 days, I don't remember. And it's not necessarily your cost. You could have only billed, $500 for that melanoma resection, but all of the other costs are getting fed into that. You do want that total cost to be low, but that doesn't necessarily mean that you as a provider are going to charge less. That means that what you need to do is you need to look at all of the services surrounding that episode and figure out if there's ways you can decrease the total cost and hopefully still maintain or even increase your revenue from that. We find that if you go back to TPCC, a lot of times what you can do is by increasing your revenue, by taking more care of that patient, you can decrease the overall cost. So I just want to point out that while we're saying a lower number is better on this screen, that doesn't mean that you as a provider should bill less. I know it's confusing. And I hope I didn't just confuse it more.
So I think what you're saying is if your practice has a better cost per service, then you would have a lower rate doing the services yourself.
That could be part of it, sure. You could bring more services in-house. That would be one way to do it.
Okay. I see there's another question about the lumbar fusion measure. That is included. The example that we had was not showing every single measure in the system, so that it might not have been on that screen, but it is included in our system. So this is a chart showing scores for 2022, and you can see the spread here a lot. Obviously, the lowest row there, 27 to 30, is the best score that you want, and we have a lot in the 15 to 18 range, and we have a lot in the 0 to 3 range. So this is definitely something where a lot of people need to improve, and there's lots of room for that improvement. And so this is out of 1,000 scores, and yeah, this distribution, you can see how low it skews here. This is where I'm going to talk about our products. So MIPS Cost Analytics, we have lots of different options. I'm going to show you some of our screens, and you can see how easy it is to analyze your data using this product. I'll go over some of these points here. So you can rank your providers and also your patients. We allow you to look at every provider and patient for each measure. So within a measure, you can see providers who are involved in the services around that measure. You can see patients who are receiving those services, and you're able to sort and filter those by cost or by several different metrics that basically any kind of data you want to look at there, we have a very flexible way to view that. You can also see services that are provided outside of your practice. So like it says here, identify costly providers. This gives you a lot more flexibility to understand where costs are coming from and understand what your patient's care journey kind of looks like and where your patients are going when you might not be aware of it. We also specifically break down costs for each provider into inpatient, outpatient, and professional services. This gives a more detailed view at where exactly each provider's costs are coming from. And then we can see claims for patients and look at what services are being received by each specific patient. If we know a patient is requiring a certain type of care, we can look at the claims there and see whether or not that's being done. Also, a really valuable part of our system is, as we mentioned before, CMS does a lot of risk calculation, and it's pretty complicated. Not to like toot our own horn, but we have spent a lot of time working on these calculations, and we have our own algorithm to calculate the risk and to, as closely as possible, simulate what CMS is looking at and compare your actual costs to your risk-adjusted costs in order to see how you're being judged on your costs, and then being able to compare that to your own records, which are probably not going to be risk-adjusted on your own. So yeah, all of these I think add up to a lot of really powerful tools to get into your cost data and really understand on a deeper level what's going on with your practice and what's going on with your MIPS scoring. So I showed a little bit of this before. Here is, we call it the measure summary page. It's kind of our dashboard where you can look at your scores and look at all of your eligible measures. You can see there's a drop down to look at different years. If you, if you sign up, typically we will be able to provide your data from the past year or two, and then we use that to calculate measures for the current year. But across multiple years, we can save up your data and let you compare across years how your performance has changed. We also have a little button there that says first factors. This is a separate analytics page that shows some simple graphs to help you understand who are some of your highest cost patients, and just kind of outlining patients that you might want to pay extra attention to. We can see here that so each measure here, this one qualifies for 5 measures, and we're able to drill down into each one of these and analyze separately the costs. Here's another example where we can add up the decile scores and see what the final cost score would be. So you can see this practice has some scores above 5.0. We're adding up the potential points to see it's out of 50, and they got a 30.6, which totals to 61%, giving them an 18.4 out of 30.
Hey, Daniel, it's Mike.
Yep.
A couple people are asking on here, where do we get this data? And I thought it's a good opportunity for you to share kind of what we did to get this data.
Yeah, absolutely.
That's
So
4 questions, the same thing.
okay, great. So we are part of what's called the Qualified Entity Program, and that enables us to work with, companies who are partnered with CMS, and they have what's called a data warehouse, and that's full of Medicare claims. So when we have a client that we're working with, a customer for this product, we will take their TINs and submit them to this company, so they can go into their data warehouse and find every patient who was involved with any provider who was involved with that TIN. So we get a massive amount of data, basically a comprehensive report of claims for each patient that has any kind of connection with your TIN or your practice. And then we receive basically a giant data dump with all of those files containing all of the claims. We get Part A, Part B, and Part D claims, and then we put those into our own database, and we run them through all of our calculations. So basically the data is directly from CMS. They are kind of, like I said, we're working with kind of their partner. So we're getting all official claims data through the CMS Medicare program, and then we provide our own analysis on top of that. Mike, do you think I have any more details about that we need?
I think you nailed it. Thank you.
All right, thanks. So here we're looking at our TPCC measure, total per capita cost. A lot of you are probably familiar with it. This is the first page you'll see when you go in to analyze this measure. We have a filtering system where you can look for certain elements in your data if you're looking for a certain patient or a certain provider, or if you want to say, as in this example, I want to see any provider who had 20 or more patients. Maybe I want to see any provider whose costs were over this amount. You can add all kinds of filters in here to get the exact picture you want and narrow down the data to just whatever you want to look at. There's also on the top right there, you can see a risk adjusted toggle. So what that's going to do is by default, this will show you the risk adjusted cost values, which are really important for CMS to be determining your costs. These are basically everything that goes into your cost score. But if you turn that toggle off, you will see the actual payment amounts, and that will help you understand from your own records how much actually was billed for each provider, each patient, or each service. We go down into several levels of detail there, and it helps you understand what kind of adjustment is being done on your cost amounts to get the full picture of here's how much was billed, and that equates to a certain amount based on the patient's risk and all of the factors that go into that. And again, there's a column for inpatient and outpatient professional for each provider. We also compare the providers billing from your TIN with outside TINs, and you can see how those compare to each other. Next slide, thanks. So once I've selected a provider, or I can first look at all my patients in general, but I also am able to narrow down a provider and see who had a relationship with this provider and where were the services being provided. So here's a list of every patient. You can see 50 patients here that were seen by this provider and how many months. So with the new or newer version of TPCC, every patient is kind of divided into these 13 beneficiary months. So they can kind of slice up the care over the year into equal amounts and then measure how the performance was for each month, rather than previously each patient was simply attributed for a whole year, and it created a lot of confusion. So right now, we look at the data in terms of reporting year. So you can see if a patient was attributed for 13 months, that means a full year. But if a patient has 12 months, as you can see, or 7 months, that means that part of the year they were not attributed. So the provider would not be responsible for those costs, but only for the specific 7 months will they have the costs attributed. Then you can get into how many candidate services were rendered. So this helps you understand where the actual relationship begins and what is triggering the cost attribution to associate the patients with the providers. You can also see the patient's cost with that provider versus overall. So you get an understanding of how significant the relationship was between the patient and the provider. And the next, so this is our newest TPCC upgrade. We are showing a risk score chart. So when you look at a specific patient, you will see all of the attributed months and then the risk score for each month. You can also see the dark blue is a fully attributed month, and the light blue means that there was a partial month there where the patient became attributed partway through the month, and then their attribution would end at that same time a year later. So you could see for this patient, they were attributed sometime last year, and then that attribution kind of ran out in the 3rd month here, but then it picked back up again in the 5th month, and it continues on for another full year at that point. And then you can see that their risk score went up a little bit and then down near the end of the year. So we also, if you were on this page, you could mouse over any of these and look at what the actual score is. You can see it's between 1.5 and 1.8, but we have all those specific numbers available. And then we have a kind of division down here of each claim type and how many we had for this patient across the year. You can also compare Medicare payment and standardized allowed amounts, and then drill down into a type of claim, or just look at all the claims in general, which is just a total of each claim type. So once we've drilled into a claim type, here we're seeing outpatient. This is a list of every outpatient claim that was attributed across this year. You can see the diagnosis as well as HCPCS and DRG codes and the description of the services provided. So this is just an even more granular view of what exactly happened with this patient and where did all of their costs come from. You can see one cost there is over $2,000. And then you can also see for each beneficiary month, we have those listed down the left side. And you can see that for the 2nd month, they had a 1.608 risk score, but then in the 5th month, it was up to a 1.687. Not a huge change, but you can track that and kind of see what services were involved in those calculations. So yeah, that's
where I take over.
yeah.
Thanks, Daniel. Really appreciate it. And thanks, Lauren, as well. There's a couple slides here. I know we're coming close on time. I know we were able to answer a number of questions during the presentation, but there were some very specific specialty questions and so forth that we'll be able to reach out to you after this. You should hear from us at the latest by early next week on all of them, because this wins for the most questions we've ever been asked. So appreciate all the questions that came in, and keep them coming while I finish this off here. So we talked about cost scoring and MVPs in the beginning. CMS will calculate your performance on the cost measures that are included within your MVP. So having chosen an MVP instead of doing traditional MIPS will limit the exposure you have to multiple cost measures. So for instance, if you are a hospital system that has 15 or 20 of the cost measures established for them or counting and attributed for you for the previous years, if you did an MVP, you can avoid most of that exposure by limiting it to only the measures that are within the MVP. So if you choose an MVP that has a cost measure you have no attribution for, that cost will be reweighted in that scenario. So you get between 1 and 10 points for each of the cost measures, and then it's going to be added into, just like your MIPS score, the same percentages and everything. We're going to spend some time later this month going over MVPs and costs and do a whole nother presentation, as we didn't really have the time today to include it in this presentation. So stay tuned for that. So taking the next steps, what things you can do right now to help get your return on investment. See what your MIPS score is. Go on to the QPP site, find out what your score is, what it was for 2022, how you can, what measures are you being attributed to. You might not know, as a lot of questions came up about the PA and MP stuff earlier. There's nothing you can do besides tell CMS that they shouldn't do that anymore. If you have PAs and MPs, they will be counted for TPCC no matter your specialty. So the best thing you can do is utilize a program like we have here at MIPS Cost Analytics to be able to attack that and take a look at it and see what your scores are to make those changes and to make the changes that allow you to reduce your impact on those cost scores. And once again, I know Lauren mentioned it for a minute, but there really is a big difference between revenue and cost. Your revenue is the cost associated with what was billed within your tin. The cost associated with these measures is everything across all that patient's episode, or in the TPCC case, across that patient for the whole year. So what I'm trying to get at is that there can be changes that you make within your organization to help reduce your costs, but not reduce your revenue. And start understanding what goes into your score and make those improvement plans. We do have another webinar coming up in September. We should probably have a couple of them. One will be on MVPs and cost scores, so you can be able to do that. I did want to share before everybody pops off here that as a special for coming on to our webinar today, you will have the opportunity to purchase our cost product by September 8th. If you are just purchasing cost, if you're doing your MIPS through your EHR or some other way, and you just want to purchase our costs, you will get $50 off per provider off our retail rate. If you are adding it on to an already purchased package through HealthMonix, or you're purchasing our enterprise package through HealthMonix, you will get $30 off. Each one of these need to be done through a phone call to my team or an email to me specifically. You'll have those contact informations on the next page, as well as in my follow-up email. This is for new purchases only, and the purchases need to be made by September 8th. To contact us, you can reach out to contact@healthmonix.com, or if you want to contact me directly, mlewis@healthmonix.com. There's our phone number that will get one of our representatives to help you out, or you can visit mipspro.com to see our different packages and our different options. I wanted to take this time to say thank you once again to Daniel and Lauren. I really appreciate the time you spent. Thank you very much. And I know that this is a very difficult, data-driven topic, and may have been, above a lot of people's knowledge of what it is and costs, but it is important and imperative moving forward to get an understanding of this. 30% of your score, when the minimum to avoid the penalty is 75, will kill you if you don't do really well in these reports on costs. So please reach out to me if you have any questions. I hope everybody has a wonderful Labor Day weekend, and we look forward to speaking with you soon. Thank you.